Hi, I'm Dr. Gaemia Tracy, veterinary neurologist, and I'm here to talk to you about medical and surgical management for intervertebral disc disease. Let me tell you a little bit about myself. I attended undergraduate at the University of Pennsylvania in Philadelphia and went to vet school at The Ohio State University. From there, I did a small animal medicine rotating internship at Carolina Veterinary Specialists in Charlotte, North Carolina, followed by a 3-year residency at North Florida Neurology, a private neurology-only practice in Jacksonville, Florida. Intervertebral disc disease is something that I manage daily in practice. Intervertebral disc disease, IVDD, in canines is a pathological condition characterized by the herniation of disc material into the vertebral canal, resulting in subsequent compression and injury to the spinal cord. This course aims to provide veterinary professionals with a detailed exploration of IVDD, encompassing its mechanisms, clinical manifestations, diagnostic modalities, therapeutic interventions, and preventative strategies. An understanding of the anatomy of the intervertebral discs and the spinal cord is very important to this discussion. So let's talk about that for a second. In between each vertebrae is a disc that I think of kind of like a jelly donut, where it has a hard outer covering and a soft jelly filling. In this disease, that soft jelly filling becomes more of a calcified, gritty material that then ruptures that outer covering. That material compresses the spinal cord, and that's what causes our problems in intervertebral disc disease. Noteworthy risk factors for disc herniation encompass degeneration, specific chondrodystrophic breeds such as dachshunds, beagles, French bulldogs, and heightened physical activity. Mechanistically, disc herniation can be attributed to either Hansen type 1, involving dehydration of the nucleus pulposus and subsequent rupture of the annulus fibrosus, or Hansen type 2, characterized by fibrous degeneration and dorsal bulging of the annulus fibrosus. The mechanism of injury, specifically contusion, triggers a cascade of events involving calcium influx, enzyme activation, oxidative damage, inflammatory reactions, and glial cell activation. The resulting pathology leads to axon loss and white matter, Wallerian degeneration, and demyelination, often speculated to be induced by compromised blood flow. Clinical manifestations of IVDD are contingent upon a specific region of the spinal cord that's affected. Cervical spine involvement typically presents with tetraparesis, tetraplegia, hypermetria, neck pain, and low head carriage. Lumbar spine engagement results in paraparesis, lumbar pain, urinary fecal incontinence without paraplegia, and altered reflexes. And tail disc herniations are discerned by signs such as low tail carriage, severe tail pain, and abnormal tail positioning. Diagnostic modalities for IVDD comprise a systematic approach, including general physical exam, neurologic assessment, and radiographic evaluation. Advanced imaging techniques such as computed tomography, CT, magnetic resonance imaging, MRI, and myelography, supplemented by laboratory assessments including a chemistry profile, complete blood count, and urinalysis, aid in achieving a comprehensive diagnosis. Differential diagnoses encompass inflammatory spinal cord diseases, spinal neoplasia, vertebral anomalies, and fibrocartilaginous embolism, otherwise known as spinal stroke. Although this could be a full lecture in and of itself, a neurologic assessment typically consists of cranial nerve exam, which is evaluating menace response, facial sensation, nasal sensation, oral sensation. Also evaluating spinal reflexes, such as the patellar reflexes of the back legs, withdrawal reflexes of all four limbs, spinal pain, which is done by palpating the neck, the back, and the tail for pain and reaction. Sensation in the toes. Make sure pets can feel their toes. If you pinch between their toes, they react appropriately, meaning they let you know. They can feel it by turning to look at you or sometimes even bite at you. Or checking for gait. Are they able to walk? Are they weak in all four limbs? Are they weak in just the back limbs? All of that goes into assessing your patient neurologically. So now that we've discussed diagnosis, let's talk about treatment of intervertebral disc disease. The therapeutic approach to IVDD is dichotomous, involving both medical and surgical management strategies. Medical interventions are indicated for patients with a modified Frankel score of level 1 or 2, high anesthetic risk, or owners opting against further diagnostics or surgical interventions. This involves strict activity restriction, anti-inflammatory medications such as steroids and non-steroidal anti-inflammatory drugs, and pain relief measures. Conversely, surgical treatment becomes imperative for patients with a modified Frankel score of level 3 to 5, repeat or severe back pain, or owner preference for surgical intervention. Surgical methods encompass definitive diagnostics, such as radiographs, CT, or MRI, followed by hemilaminectomy for herniated discs in the thoracolumbar spine, or ventral slot decompression for herniated discs in the cervical spine, or dorsal laminectomy performed on herniated discs in the lumbosacral spine. When a pet presents with intervertebral disc disease, they can present in various levels of pain, weakness, or paralysis. That level is determined on a modified Frankel score. The modified Frankel score goes from level 1, which is the least severe, to level 5, which is the most severe. I'll go through each level step by step so you can understand what each one comprises. Level 1 is pain only. Patients are able to walk, but they're just not as active as normal. They're not jumping on things, and they're painful on palpation. Level 2 is called ambulatory paraparesis, which is kind of your ataxic, I tell owners, drunken sailor type gait, where they're able to walk, but they're uncoordinated in the back end. Level 3 is non-ambulatory paraparesis, where they're not able to walk, but they're able to move their back legs, wag their tail. So I kind of describe this as your wagging and dragging patients. Level 4 is paralysis or paraplegia, where they no longer have movement in their back legs, but they're able to feel their toes and tail when they're pinched. And then level 5 is your worst case scenario, where they're not able to move or feel their toes or tail when they're pinched. So this modified Frankel level score guides recommendations, prognosis, and treatment options. Prognosis in IVDD management is contingent upon the chosen therapeutic modality. Medical management typically yields a 50 to 70% recovery rate with a 50% recurrence for modified Frankel scores of level 1 to 4, while surgical treatment boasts a 90 to 95% recovery rate with an approximately 25% recurrence. Preventative measures involve lifestyle modifications, discouraging activities that stress the spine, and the innovative percutaneous laser disc ablation, or PLDA procedure. PLDA, a minimally invasive prophylactic laser procedure, serves as a preemptive measure against disc herniation, particularly in chondrodystrophic breeds with a history of IVDD. Employing a holmium yttrium aluminum garnet or HOYAG laser, the procedure vaporizes the nucleus pulposus, reducing intradiscal pressure and minimizing the risk of disc herniation. The procedure is associated with advantages such as minimal invasiveness, reduced morbidity, short procedure duration, and a decreased rate of disc herniation. It takes your typical 20 to 25% rate of disc herniation in chondrodystrophic dogs and reduces it to 3 to 10%. Post-PLDA, patients necessitate controlled leash walks, crate rest, and a pharmacological regimen including gabapentin and carprofen for a period of 2 weeks. PLDA, developed in 1993 by Dr. Bartels at Oklahoma State University, initially demonstrated a success rate of 97% in a 2003 study. A subsequent investigation from 1994 to 2011, conducted by Dr. Dugat, reported an overall recurrence rate of just 3.6% among 303 dogs, with 92.7% of owners expressing satisfaction with the procedure. Before we go, I would like to take a moment to cover some case studies with you on this particular disease. The first case study is a 4-year-old male neuter dachshund. He presented to me with movement in his back legs, but he was unable to walk. So on his neuro exam, he had a modified Frankel score of 3. When I evaluated him, his reflexes were normal, but his conscious proprioception was absent in his back legs, which means when I flipped his feet over, he was unable to correct them. So we concluded with these findings that there was an issue with the thoracolumbar spine. From there, we did an MRI, which confirmed a disc herniation. So we performed a hemilaminectomy to decompress the spinal cord. He was kept in the hospital for 3 days. After that, he was discharged. At home, he was managed for 2 weeks with activity restriction, pain medication, anti-inflammatory, NSAIDs. On his recheck in 2 weeks, he was able to walk, but he was still wobbly. So over the next 4 weeks, I recommended slowly increasing his activity level as well as incorporating physical therapy in his treatment plan. In his recheck after that, his gait was nearly normal. In case study 2, let's talk about a 7-year-old female spayed French bulldog. She presented with ambulatory paraparesis, which is a wobbly gait. So her modified Frankel score was level 2. These owners, because she was still able to walk, although it wasn't normal, opted for medical management. She was treated with nonsteroidal anti-inflammatory medication and gabapentin for pain. I recommended restricted activity at home, which means primarily crate rest for 4 weeks, taken outside to go to the bathroom, and immediately returned inside for crate rest. On her recheck, her gait was improved, it was more stable, and she was non-painful. Over the next month, we slowly increased her activity level until she got back to normal. Her prognosis was also good for recovery. So that shows that there are medical and surgical treatments for intervertebral disc disease. Case study 3 is an interesting one. So he was a 2-year-old male neuter French bulldog, but this owner had experience with a previous pet that had intervertebral disc disease in which they needed surgery to improve. So she reached out to me asking for preventative measures for herniated discs in these dogs that are predisposed. So I recommended PLDA for this guy. Dogs that I recommend PLDA for are usually chondrodystrophic dogs that are active, typically young to middle age. These dogs have to be 2 weeks pain-free and medication-free prior to the procedure. This is to ensure that they do not have an active rupture in a disc, because in using the laser to ablate the disc, we can actually push material out and cause a further problem rather than preventing it. So the PLDA for him was performed, and then following the procedure, he was kept overnight. He was treated with pain medication as well as nonsteroidal anti-inflammatory medication. He was reevaluated the next morning. He was doing well, his gait was normal, and he was pain-free, so he was discharged. At home, he was activity restricted for 2 weeks and treated with 2 weeks worth of anti-inflammatory medication and pain medication. On his recheck, he was still doing well and he was comfortable. So we resumed completely normal activity after that 2 weeks. This comprehensive understanding ensures that veterinary professionals can provide optimal care for canine patients grappling with the complexities of intervertebral disc disease. And that'll be all for our talk on intervertebral disc disease. Thank you so much for watching. Want to keep up with everything vet med? Follow us at MyVetCandy.